The things you asked them about, contrast dye and metformin are not good company together. So we already know this person is, if they're taking metformin, they either have glucose intolerance or they're diabetic, right? So that means I could have impaired kidneys when they go. Look at BUN creatinine before the patient goes for a test, because dye will be based, the amount of dye they give a patient will be based on what those numbers are. Because you cannot do the test without dye, I'm just saying. But they will adjust the amount of dye they use for a patient based on their kidney function test. So you're going to look at BUN and creatinine for that patient. You ask them if they're taking metformin. Now if it's an emergent procedure, I don't care because I got to do this. But if it's scheduled, you hold metformin 4 days before and 4 days after the test. That's how big it is. You know, it used to be 2 days, now it's 4. Because it holds contrast dye in the kidneys longer, which can lead to intrarenal failure. Because that's what contrast dye is, one of the issues that you have for causing intrarenal failure. So if you have a person that had to, you know, I took it at home and now I had this change, what generally happens, yes, I'm going to still do my test, they'll hold the medication, but those are people that usually go on IV fluids. Because I want to try to flush it out as quickly as possible. Because when your patient goes to cath, they have fluids for a little while. Usually when you got a patient who has issues and took metformin, they're on IV fluids for at least 24 to 48 hours. You had a question?
I just want to let you know how to explain myself.
Okay. No problem. Okay. So those, if the patient's going to do that, the other thing is this is one of those core measures when you talk about patients having unstable angina. Chest pain presentation in the ER is a core measure. So that goes along with that acute MI. They want patients who present to the emergency room from the ER into the cath lab within 90 minutes. That's the goal. That is the national standard for getting a patient who comes in with chest pain. I want you evaluated and in the cath lab in 90 minutes. Now, of course, every hospital right now, even though that 90 minutes is what is standard for the core measure, every hospital tries to do it within an hour. Because the better you are, the more reimbursement you get, kind of thing. So those are things that you're going to see from your patients. So that's one of the things, you know, how in life I told you to be able to speak to some things when you're looking for a job. Core measures are those kind of things, to be able to actually do that. All right, so acute coronary syndrome, you may also see some other lab work done. So they will do the CPK. Or you may see it written as CK. Same test. Now the thing about this is CKs are things that are considered, if you have a person that's over 150, then they're going to do what we call fractionated. Okay, so you're going to get this result, and they're going to fractionate it so you can tell what it's from. Okay? MDs is myocardial band, so you know it's heart. Okay? They also have BB, which is for brain. Some people have MM or some have SS, that's for skeletal muscle. Now the reason that's important is because it can be positive. It can be 40,000, and you're like, ooh, that person had a big heart attack. No, not necessarily. All right. The reason being is that anytime you get hit, if you had a person that fell on the floor at home and you were laying down for a long time, that causes muscle to break down. So that would be positive for here. That's why when you get a 150, they're also going to tell you what it is here. So if it's 0, it's not the heart. See what I mean? If it was the heart, that would be high. And the reason you do those is because sometimes you'll have if a person has a stroke, this one is going to be high. The other two would be negative. So it's going to tell you exactly which tissue is affected in the patient. So CPKs are going to do that. But you're also going to see, which is considered the most indicative of what's going on, is troponin. The reason being because CK, one of the other things that happens with CPK is it has a rise and fall. And so it rises, goes up, and usually peaks and comes down within 36 hours max. Troponin stays positive for as long as 2 weeks. So I can tell if a person has a heart attack. Okay, even if they don't come in today, You know, we had a good game on Sunday, so I wasn't having a heart attack. But when it's a bad game, you know, you're sitting there going like, man, this is going to be the death of me, kind of thing. So you don't know if it's the game or you're really having a heart attack from eating the wings. You don't know if that's exactly what's going on. So when you do that, you know, 3 days later, CPK would be negative anyway, but troponin would still be positive. So that's why you can use it as a longer period of time test to tell whether somebody had a heart attack. All right? So it stays positive longer.
Okay, now what was the difference between the CK and the MB?
It's the same test. If it's positive, meaning that if it's over 150, they're going to fractionate it and tell you which cells are affected. So that if it's, they're going to do the whole thing that says whether it's MBs, MMs, or BP to tell you which area is affected. It's the same
CK
test.
is just the overall test, and then they break it down to MB?
Right.
Okay.
Because they're gonna, it's like different parts. If you can, because if you had a patient who had polymyositis, which is a generalized muscle inflammation that is all over your body, because that's the person I saw with 24,000 on their CPK. You're going like 24,000. So, but when they did MBs, it was negative, so it wasn't heart, it was skeletal muscle. So it'll be positive when they get a positive or the result is high enough to be considered a positive test. Then they tell you which muscle was affected. Was it heart? Was it brain? Was it skeletal muscle? But just know it can be positive. I mean, you get that really high number, and the first thing people freak out about, but if it's not MBs, it's not the heart, it's somewhere else in the body that's affected. So troponin stays positive longer, so that's why you do those. And those are things that you see that hospitals order every 6 hours times 3, or every 8 hours times 3. You'll see that they do that, because they're going to have a rise and fall that goes with them, but once troponin is positive, it stays positive. Okay.
And that's specifically for heart attack.
Right. It's going to be the most specific. The only person that you have to, and this is something that has come out in literature in the last couple of years, the other people that have a positive troponin that truly may not be having anything heart or kidney patients, their troponin levels are high. So they have to make sure they do that correlation to find out whether or not they're having a heart attack or not. Yeah?
Does it make a difference with troponin T or I?
Well, most of the time when you see in the hospital, they're doing I. But because it's the cheaper of the two tests. But it all depends. Most people don't, I mean, as far as making the definition or difference in the hospital, they don't even tell you which one they're doing. They just say troponin levels. The other one that you might see done is myoglobin. Went away for a long time as far as testing goes on a patient. And I'm not asking you about if you're, you know, what the levels are kind of thing. Just know what tests they do for the patient. Myoglobin is something that went away. We used to use it all the time to see whether a patient had a heart attack, mainly because it comes from the heart. And if you have a patient who has a heart attack, it's not just specific to myocardium, that's what the issue was, but it rises and falls really quick. So, but this one you can test within 30 minutes of onset of chest pain, and it will be positive. So that's why it's come back again, as far as people being able to use it. What they did was make it a more sensitive test. So there are some biomarkers for cardiac in it now. So they're actually able to do it at the bedside. You don't have to send it to the lab. That's the other piece that goes along with it. Because you know most things we send off to the lab, but you can have things at the bedside and test for myoglobin now. So that may be something that you see tested on the patient as well. Then they're going to get their EKG, of course. They're going to look for these types of changes that are talking about ischemia in the patient. And then they're going to give their treatment. Now, if they went for a cardiac cath and we opened up that area, one of the things you got to think about for those patients, pretty much they're going to be on the same types of drugs. Nitrates at home, aspirin, because you want some antiplatelet agent that this patient is taking, unless it's contraindicated for them, because you know everybody can't take aspirin. If they did have some type of stent placement, you're going to see Plavix. Okay, because you got to keep that stent open, and that's what we use to keep stents open. Probably some of those other ones are going to join that group, but right now they haven't had the full clinical trial to do reports on them yet, because they're trying Eliquis and all that kind of stuff for those yet, but we don't have the results on those yet. They also go on the Holy Trilogy for patient, you know, we talk about patients being on, you know, atherosclerosis is the piece, so that's why they're on the statin drug. They may be on a beta blocker. Even if their blood pressure is low, put them on low dose beta blocker because that protects myocardium. Okay, so you probably see Coreg or something like that the patient is on. And then it's going to be lifestyle modifications. What do you need to be doing different to help improve your symptoms? Low cholesterol, low fat diet, decrease sodium, stop smoking if you're doing those types of things. But that's where it comes into teaching the patient and making sure they understand about their meds.
Statin, beta blocker, and aspirin.
Uh-huh. All right. So acute coronary syndrome will be that person who comes in, never had a problem before. Usually these are generally people that you see early 40s, early 50s who never had a problem before now having a heart attack. There was a commercial on TV one time about a nurse. I know y'all see, all you do is watch TV. But I watch the drug commercials on TV because I think it's crazy. I remember as a kid, the only thing I saw on TV was aspirin, Pepto-Bismol, and Kaopectate. Now they have every drug that's out there to treat every disease on TV, so people go and ask their doctor, can I take this drug, kind of thing. But this was a commercial about Plavix. Okay, and it was a woman, I don't know if you remember it because it doesn't even come on anymore, but she was a nurse, and she was talking about she got brought to her knees by something that's smaller than the head of a pin. And what happened was she had a clot that happened and she had a heart attack from the clot. So those tend to happen in people who don't have any problems before. There's a clot that forms and they end up having a heart attack from it. So that's acute coronary syndrome. The only thing that's different, because you have the same kind of stuff that's happening with your patient, but acute coronary syndrome is somebody that has a heart attack with no history of having any type of heart disease. Most patients have some, even though you don't talk about it specifically as a heart disease, they have some type of risk factor that is going towards that way. Hypertension, diabetes, sedentary lifestyle, that kind of stuff. Acute coronary syndrome are people who never had complaints of anything and all of a sudden have a heart attack. And it's usually a thrombus that's the problem. Okay? So those people are worked up the same way, because guess what? We got to worry about that happening with the patient. So they go home on the Holy Trilogy as well. They go do the same thing about the cath lab. So yes, it's a different disease process, but guess what? We treat them the same. Just a different mechanism about what's happening with the patient. Now, with a patient who has an acute MI, a little bit different. We've gone from ischemia now to tissue death. So this is the one that if I let it continue on, then I'm thinking about tissue dying off for this patient. So when you have a patient who has a heart attack, my little crazy heart, okay, so patient has the blockage. Now think about where you have the area blockage. You always think about, and this is how I'll give you the context of it, is think about when you're sitting someplace comfortable, but you're sitting on your foot. I didn't even know you were going to be doing that when I looked over there. But you're sitting on your foot, and you notice when you put your foot to the floor, what hurts? The toe. The foot feels numb, right? But the toe is like, ouch. All right, because that's the farthest away. That's what you've cut off blood supply the most. So this is kind of picture what happens when I have an area that's not getting blood supply. The farthest away is going to be necrotic because it has the least blood flow going through it. The area of injury, which means that part of what I got those backwards. Whoop. Sorry, y'all. I had a moment. I'm losing my mind. All right. So when you see what's happening with your patient, the farthest away is going to be necrotic. The area around that is going to be the area that's more ischemic. So closer to your toe is going to feel number. And then the area all the way around is the area right under the clot from where it starts is going to be the area of injury. So if you think about how far that clot may be up, think about how much of the pumping force of the heart you can take out with a clot. So that's how you have to think about it. I'm going to have a part where tissue dies. I don't want that to happen. I'm going to have an area where I have severe ischemia, not quite necrosis, but not as bad as necrosis. And then this is the whole area of injury I have. That's what happens when you're talking about a patient having a heart attack. The other thing about having a heart attack is when I put a person on an EKG, I'm going to see some changes on my EKG strip. So a person is going along, doing their thing, and all of a sudden you start seeing, you start to see ST elevation. So the ST wave is coming up. I'm killing them off too quick. Because you know I'm going to kill them, right? Because everybody dies. Sorry. I'm not killing them. This is the one I'm talking about now. All right? So your ST, this is a ST elevation MI. When you see a ST segment go 30% or greater, meaning that it rises 30% of what that QRS complex is, that's what they call a ST elevation MI. So you're looking at the ST segment. So ST elevation MI, also known as STEMI, okay, because that's what they're talking about when you say a patient has a STEMI. ST elevation MI is a patient who has, if you have chest pain less than 6 hours, but I will tell you, people don't like to go past 4. They really want to do it within the first hour. If I have a patient who is eligible, this is a person that is eligible for thrombolytics. That's why it's important to identify what's happening with your patient. Okay, so the thing you do, a person presents in the ER with chest pain, and this is one of those things in life, you go like, okay, you learn that yes, you put them on O2, yes, you give them nitroglycerin, yes, you start an IV, but the most important thing for a chest pain patient, because we all, yeah, time is tissue, oxygen is tissue, the most important thing to do is put them on an EKG, because it will tell me what I need to do to treat them. In real life, you know somebody's doing all these things together. But the first thing you do for testing purposes is an EKG. Because not only is EKG going to tell me, yes, the patient is having a STEMI. That means that, yes, now I need to look at your criteria, see if you can have a thrombolytic and do it. Because the goal is to get that done within that 90-minute window. If you got a patient who's a candidate, you do it right now. The patient may still go to cath. But the thing is, I want to stop this ischemia from getting so that all of this heart muscle is lost. And so that only I maybe have a little bit down here that I can't reverse. Okay? The reason I put that RIP up there, because then you'll know when you see those, we call them tombstones. Because you can no longer see a QRS complex that looks like a regular QRS complex. That tells you tissue necrosis is happening. When you have a patient who is a STEMI, you see this happening on an EKG strip, you start doing thrombolytics on the patient in the ER, they're going to go from that back to this. That tells you you've established reperfusion. If you have a patient who's still complaining of chest pain, the clot is still there. The drug didn't dissolve it. Because chest pain if you go a person is reestablished, you're going to see them go from those tombstones back to their regular rhythm that is underlying. So ST elevation should go away. That's what should happen if everything worked. Now, of course, you got to worry about the VTACs, because one of the things when you mess with myocardium, it's not happy. Okay, if you didn't give me blood supply, what's wrong with you, fool? That's what your heart is saying, kind of thing. So it's going to act up. And one of the things that happens when you have patients, when you do that, is there's irritability, and so ventricular arrhythmias are common after a patient has a heart attack. Now, the other thing about that and why it's important to do an EKG is you can tell how big the heart attack is. You know how people think just because lab work is really high, when I was talking about that 22,000 on that person. Now, of course, that was skeletal muscle, but people think, oh, just because my CPK is really high. Now, remember, when I start an IV, that's going to make your CPK go up. If you were in there and you were having pain and you hit yourself on the thing, on the side of the rail, when you hit yourself, that releases CPK. That's not going to tell you how big the heart attack is. How big the heart attack is going to tell you how many changes and how many leads do I see it in. Okay. Veronica's learned all those leads. If I see a patient who has, you know, only 2 leads are different than they normally are, relatively small heart attack. If I have 5, 6 leads where I see ST elevation, that tells you that's a huge heart attack. That's the reason why doing the EKG is important. Dictates treatment, tells me how big the heart attack is in the patient. Yeah.
But like one kid already had like some type of cardiovascular event, like their EKG has changed, and it won't go back to like normal or anything, right? They'll never have like a normal EKG again.
Right, but the only thing, if you have a heart attack previously, and that's how doctors can tell, when you have a patient who has had a heart attack and they're going, and they say, you can ask the patient, when did you have a heart attack? And they go like, I never had a heart attack, because that's what they, no, I never did that. How they see it is that the patient actually has a reciprocal change, meaning that something that's supposed to be an upright lead is now downward. So if the witch hat is supposed to go this way, it goes this way. Okay, so they have a, you know, so lead 1, 2, and 3 are upward leads. Okay, so if you were monitoring the patient, lead 1, 2, and 3, if you were doing that on a monitor, those are upright leads. So if I saw a lead 1 that was going this way, I can tell that's where you had a heart attack before. So that's what a patient does. So if I've seen that reciprocal change in a person before, now if you don't have anybody's history, that's the problem, because you don't know whether that's new or how old that is in the patient. But the thing about it is they would still have, the ST segment would still show, but it would just show it in opposite direction than it should be.
I have a lady with all downward and high blood pressure all the time.
Yeah, and that's what it does. That part of it is why you have to kind of make sure you know their history to see what's going on. But that's the thing about it is it will turn everything opposite. When you hurt the heart, it mirrors back opposite of what it used to be. So if you had your heart attack in the area where lead 1 monitors, because when you hear people talking about, and I'm not going to ask you whether the patient had anterior lateral heart attack, because that's kind of stuff you do in your advanced courses. Because there's different leads you look for to say where that is. And if you were looking at, I mean, it's in that section too where you talk about lead 1 and 2. And basically what it's doing when you change the leads on an EKG strip is that you're looking at different planes. You know, the positive, negative, and the ground change. And so what they're doing is looking at the heart from up top in this way, up from the bottom. When you change the positive and the negative, that's what it's doing. So it's just giving you a different picture of the electrical system at different points around the heart. And then the chest leads, which are the V1 through V6 that go across the chest, those are things that are actually just looking at, pretty much give you a size, because those are things that change usually when a person has pericarditis, that kind of stuff. You don't see a lot of stuff that's happening there unless the person had a huge heart attack and now it's affecting the surface of the heart, because those are what the V1s look at. So those are things that, you know, when you see a lot of changes going on, that's the bigger the heart attack is. And in your head, you're thinking about the bigger the heart attack is, the complications you got to look for. Small heart attack, people usually do fine. That's the thing. You have a person that comes in, yeah, I had a small heart attack, and the patient's home in 4 days. You're going, how'd they go home? Because myocardium has been preserved. But if you got a big old heart attack, remember, if it's not pumping efficiently, you lose the pumping force of the heart. So if a big heart attack, 6 leads, usually has heart failure as a result of having a heart attack. So it's stuff that kind of comes into play when you're doing that with your patient. Yeah.
So if they're down like that, does that mean that it's necrotic tissue then from the previous? Is that what you're saying?
Yeah, if you have something that's supposed to be positive,
right.
So the person had the heart attack now, I mean previous at a time, it changes it so that it mirrors to opposite direction. So instead of being a positive deflection, that's what they call upward deflections, it'll be a negative deflection. So a lead 1 that's supposed to look like this, lead 1, 2, and 3 are positive leads. There's some other ones, but those are the main ones that they monitor people for in the hospital. So instead of looking like this, it'll look this way. You will still see the ST elevation, but it'll just all be downward, in a downward deflection. So it's still there, but it's just opposite of what it should look like. So that always tells you previous damage.